again, I would like to invite and hear from Dr. Lai on surgical treatment of unclosed large macular holes in highly myopic eyes. Dr. Lai, please.
Thank you very much for the invitation. It's my great honor and pleasure to present the surgical treatment of unclosed large macular hole in highly myopic eye. I'm from Taiwan. So this is my financial disclosure. So vitrectomy and iron peeling is a routine procedure for treatment of macular in highly myopic eye, and we could close most of the macular hole in this case. However, if the hole if the macula is associated with a highly myopic eye with axial length longer than 30 millimeter, associated with myopic foveal schisis and staphylomas. At this situation, that the macular hole maybe could not close even with the second or third surgery. So Dr. Kuriyama from Japan is the first one to use the iron flap to treat the macular hole in the myopic foveal schisis. As you could see, with this flap technique, it's about only 80% of them could close the macular hole in the first surgery. But this study shows that the iron flap will helpful for us to close the macular hole with a high risk in the high myopic eyes. So there's two techniques. One is a flap coverage. The other one is insertion. We all know that the insertion could increase the anatomical successful, but however, it will hinder the visual recovery. So now most of us will use the flap coverage technique to cure and to treat the macular hole in highly myopic eyes. So today I will show you how we use the flap technique to management of the unclosed macular in highly myopic eye with remain iron flaps, lens capsule, and the embryonic membrane. And you could use this I call spot technique we developed to stabilize and management all these large flap to treat the macular hole in the high myopic eyes with different transparency. So I will show you with some cases. So this is a 57 years old female. Actually, she is not very highly myopic. However, he received the vitrectomy to treat the macular hole with iron peeling. As you can see, the first surgery is failed, and then he received the gas-free change. However, the hole become larger. So then we use, we could see some healthy IRM in a little far away from the macular hole. So then we can use this non-inverted iron flap developed by Professor Zhao from China. As you can see, we can move this IRM from a very distal area, and you can evaluate this free iron flap with intraoperable OCT. As you can see, it's a single layer cover the macular hole. So it's very important to use the OVD visco to fix and stabilize this flap. Or when you do the gas-free change, this free flap maybe go away. So the spot technique is very helpful for us to stabilize. As you can see here, under the perfluorocarbon, even we remove the perfluorocarbon first, and you can see the flap is very stable. And if you do the gas-free change, the flap will not go away and dislocate it. So this is another case. As you can see, he also received this free iron flap. 6 months later, the visual acuity is recovered and hole is closed. So this is another case. He also received the vitrectomy iron peeling for her macular hole. However, because the hole is not closed, and as you can see, this case, you can see actually there's not much healthy iron for this case. There's many proliferation membranes around the macular hole. So we need to remove all the traction around this large macular hole. Fortunately, he didn't do the phaco-vit, so we have a lens capsule. So we use the spot technique. As you can see, we can span this lens capsule under the perfluorocarbon. So this is a very good material for us. to close the large macular hole. So as you can see, we can move this free lens capsule and the cover on the macular hole. In this moment, as you can see, it's a single layer lens capsule cover on the macular hole. And also, we need to use the OVD to stabilize and fix this large piece lens capsule to close the macular hole. So as you can see, after surgery, the hole is closed and the visual acuity recover after the surgery. So not only in the macular hole, but if the case combined with macular retinal detachment, you could also use this technique. As you can see, he has a large atrophy and also the macular hole in the macular area with the retinal detachment. So with the Harvey's lens capsule, using the spot technique, as you can see, we can manage this large piece of the lens capsule under the perfluorocarbon liquid to cover the defect of the macular hole. So under the evaluation of the intraocular CT, you can see this lens capsule is well seated and cover this tissue defect on the macular area. And also, I think it's very important to use the dispersive OVD to fix and stabilize this large piece of lens capsule. Fortunately, we closed the hole, and after we remove the silicone oil, the visual acuity recovery, because the atrophy of macula, the visual acuity is only 0.05. So if you use the insertion of the AMG in the highly myopic eye for the macular hole, we could get an atrophy afterwards. So in our institution, we are trying to use the small piece of the AMG to close the macular hole, but as you can see, if the size is too small, it will easy to get a dislocation of this AMG. So we also use a large piece of the AMG, as you can see. This is large macula in the highly myopic eye, and also sometimes in the highly myopic eye, you could see several small macular holes around the macula. So there's an advantage to use this large AMG to cover all this defect in the macular area. And it's very important to use this spot technique to stabilize this large piece of the AMG transparent. So even when we manipulate and do the gastric change, the AMG will not get dislocation and detached. So after 6 months after the surgery, the hole is closed, and you could see the AMG is well seated on the macular area, and it seems like we can use this as an artificial IRM for this case. So this is one of my friends' wife. She is a professor in the college. As you can see, after she received a full surgery for the macular hole retinal detachment, the hole is still opened. Even we use a large piece of AMG to treat her macula in the high myopia. As you can see, the hole is closed, and she could go back to the college to teach her students. So I think it will recur with some risk factor, and I encourage you to use spot technique. Use a remain IRM, lens capsule, AMG, even with the ARG, the retinal transplant, to cure the macular hole in the highly myopic eye. Thank you very much for your attention.
Thank you, Professor.